Hello all. So I'll be restricting my talk to approach to disc edema. So disc edema, we mean the swelling of the intraocular portion of the optic disc. This causes compression of the fibers in the lamina cribrosa that leads to tissue edema and increases intracellular matrix pressure. So all the findings that we see on the disc is secondary to blockage of the retrograde and orthograde axoplasmic transport in the optic nerve. Right. There are certain signs of disc edema. We have 5 mechanical signs and 5 vascular signs. So when you're looking at a disc, look for these. So what are the mechanical signs? We have loss of cup, elevation of the disc, blurring of margins, nerve fiber layer edema, and folds. The retinal folds we term as Patton's lines, and we have choroidal folds as well. Vascular signs include the hyperemia of the disc, venous congestion, dilatation and tortuosity, peripapillary hemorrhages, nerve fiber layer infarcts, that is cotton wool spots, and exudates. Now, some of these mechanical signs can be seen in pseudodisc edema. Although number one, we've written loss of cup. Now, in pseudodisc edema, that is present early on. In established disc edema, it is a late finding, right? So remember that. However, you can also get elevation of the disc and blurring of margins in pseudodisc edema as well. The vascular signs are a little more specific. So this disc can be seen in a number of causes, right? So I cannot stress enough on a detailed history taking. Your history will point you towards the diagnosis. Spend time, discuss in detail regarding the patient about the onset of symptoms. If the uh, disc edema is asymmetric or unilateral, the optic nerve function test will be useful. For any optic nerve pathology, make sure you are seeing the best corrected visual acuity, color vision, relative afferent pupillary defect. Then we study the disc morphology and visual fields. There are certain ancillary tests which at times are useful, such as OCT and fundus photo VEP, and a focused neurological examination and cranial nerve examination might help. Systemically, blood pressure is a must in any case of disc edema. Do not forget to check the blood pressure. So there are various etiologies for disc edema. So we'll try to cover as much as these as possible with cases. So starting with case number 1, a 25-year-old female with no past medical or neurological history presented with a one-day history of decreased vision in the right eye. Visual loss was associated with pain behind the eye that worsened with eye movement. Her visual acuity in the right eye was 612 with a grade 2 RAPD. There was red desaturation on color vision checking, and the visual fields showed a centrocecal scotoma in the right eye. The disc showed right eye edema, left eye was normal. What is your diagnosis? Right eye optic neuritis. It seems to be like a typical optic neuritis, yes? So her MRI brain and orbit showed T2 hyperintensity in the right optic nerve. Yeah, and which you can see in the axial and in the coronal. So a little hint for us ophthalmologists on how to recognize T2, whether the nerve is hyperintense or not. Now, over here in the coronal section, you compare the inside. The outside is your perioptic space. The inside of the nerve, compare it to the muscles around. All right. So over here in the normal nerve, it is less hyperintense, right? Whereas in a when it is a hyperintense nerve, it is equal to or more bright than the muscles. Can you appreciate that? Yeah. So that's how you look for T2 hyperintensity. Now, this patient also had T2 hyperintensity in the periventricular white matter. So what are these called? Dawson's fingers, yes. So coming to case number 2, a 32-year-old female presented with painless decreased right eye vision since 1 week. Her best corrected visual acuity was 636 in the right eye with a grade 1 RAPD. The rest of her anterior segment was within normal, and she also, on questioning, gave a history that she had recently adopted a kitten. So her posterior segment findings showed disc edema with... Yeah, so what is your diagnosis? Neuroretinitis, right? So how do we differentiate the two? Optic neuritis is, or we'll stick to typical optic neuritis, is seen in women less than 40 years of age with an acute onset of symptoms and pain worse with eye movements and an afferent pupillary defect which corresponds with the vision and a significant color vision defect, right? Not so with neuroretinitis. So what is neuroretinitis? It is inflammation of the neural retina and the optic nerve. There is no gender predilection or age predilection. It is often preceded by a viral prodrome. There are two main types. You have an infectious or an idiopathic type, and it is not associated with multiple sclerosis. Now, coming to case 3, a 58-year-old male presented with sudden and painless profound vision loss in the right eye on waking of 1 day duration. He was a known hypertensive on irregular medication. His visual acuity was 5/60 in the right eye with a grade 2 RAPD and a blood pressure of 160/90. His visual fields done showed an altitudinal field defect, and the disc showed pallid disc edema with, this is what you can see here is a very characteristic luxuriant perfusion. So the diagnosis is NAION. Always remember, in NAION, look at the contralateral disc. It should be crowded. Okay, it has to be a disc at risk for you to definitely say it is NAION. So NAION is a segmental or generalized infarction of the prelaminar or laminar portion of the optic nerve due to occlusion of the short posterior ciliary artery. And the usual risk factors are hypertension or diabetes. Now, it is very, very important to differentiate an NAION from an arteritic ischemic optic neuropathy, because if it is a GCA associated ischemic optic neuropathy, the patient is going to be blind within 2 weeks. That is one eye affected. The next eye is prone to get affected within the next 2 weeks unless treatment is started, right? And then both eyes, no vision, patient functionally is quite handicapped. Yes. So how do we diagnose an arthritic ischemic optic neuropathy? Is with your all your investigations, ask for an ESR and a CRP to start off with. If these are elevated and not just simply elevated, markedly elevated, close to 100 ESR or CRP, consider a GCA. Now, coming to case 4, a 58-year-old male presented with a 15 days history of dull pain in the left periocular region with mild blurring of vision in the left eye. The anterior segment was within normal limits. The fundus examination showed a disc edema in the left eye with macular edema and cells in the posterior vitreous. Any idea what this could be? The ultrasound picture is this. Posterior scleritis. All right. So sometimes you will get disc edema, a patient with pain, severe pain with disc edema. All right. Keep this in mind. Posterior scleritis. Case number 5, a 58-year-old male, a hypertensive with defective vision in the left eye over 1 week, with the vision in the right eye of 6/6 and left eye of 5/60. And the RAPD showed a grade, there was a grade 1 RAPD. This was the fundus picture. Multiple hemorrhages at various levels with cotton wool spots and hard exudates. Always remember, do not concentrate only on the disc. Look at the entire fundus, because this was the entire fundus picture. So what is your diagnosis now? CRVO. All right. So now coming to the bilateral disc edema. So 26-year-old female with a headache of 1 month associated with transient visual obscurations lasting for a few seconds on sitting up in the morning. This was there since the last 2 weeks. She had pulse synchronous tinnitus and diplopia since 3 days. She gave a history of gaining 9 kgs in the last 4 months, and her menstrual history was irregular. On examination, visual acuity was 6/6 in both the eyes. The pupils were normal. Anterior segment was within normal limits. The visual fields showed enlarged blind spots, and the fundus picture showed bilateral disc edema. Here you can see all the characteristic findings of disc edema: loss of cup, a blurring of the disc margins, elevated margins, hyperemia of the disc, dilated vessels, some amount of peripapillary hemorrhages. All right. And you can see patterns lines as well. So she was advised an MRI and an MRV, which showed increase in the perioptic CSF space. Yeah, it showed concave superior margin of the pituitary gland, and the MRV was normal. So what is your diagnosis? Idiopathic intracranial hypertension. causing papilledema. Now, remember, you term it as papilledema only when there is bilateral disc edema secondary to raised intracranial pressure. Disc edema of any other cause is not called papilledema. Now, the gold standard for measuring this is the CSF opening pressure. Normal is 6 to 25 centimeters of water. Remember that IIH is a diagnosis of exclusion. So again, a detailed history and examination is crucial in cases of papilledema. Remember, IIH is very rare in males. So if you get a male patient with a normal MRI, dig deeper for a cause, right? Always exclude cortical venous sinus thrombosis. So an MRV is a must. Now, coming to case 7, a 16-year-old male came for headaches of 1 month duration, which was worse in the evening and relieved with sleep. His vision was 6/6 in both the eyes. The fields did show a mild enlarged blind spot. Color vision was normal. The disc showed elevated the disc margins, blurring of the disc margins with an elevated disc. However, there was no osculation of vessels leaving the disc, which is a suggestive of RNFL edema. There was no hemorrhages. There was no dilated tortuosity. There was no hyperemia, right? So on further investigations, there was a hypoechoic lesion on the optic nerve head, which persisted in low gain. There was also fundus autofluorescence, and the CT scan showed bright objects at the optic disc. What is your diagnosis? Optic disc drusen. So remember that if a patient incidentally has disc edema, make sure you look for the various causes of pseudodisc edema, right? Very commonly, optic nerve head drusen. The other causes of pseudodisc edema would be, you would get it in both a hyperopic disc and a myopic disc, because a hyperopic disc is a small crowded disc, whereas a myopic disc is often tilted. So the lower one, this is a tilted myopic disc, which can be confused for bilateral disc edema or papilledema, or a crowded disc as well. So now coming to case 8, a 48-year-old male with uncontrolled diabetes with blurring of vision in both the eyes. The anterior segment finding were within normal limits. Vision was 6, 9, and 8. The fields were normal. The fundus showed bilateral disc edema. Apart from that, there were a few hemorrhages in the fundus and hard exudates at the macula. So this is diabetic papillopathy. All right. So diabetic papillopathy is considered a precursor for ischemic optic neuropathy. That is, it's like a warning sign. It is the disc edema before the other signs of decreased optic nerve function. All right. And it is often seen with patients with moderate NPDR. Case 9 is that of a 54-year-old male with throbbing headache. Visual acuity was 6/6 and 6 in both the eyes. The anterior segment was within normal limits. The posterior segment bilaterally showed disc edema with cotton wool spots and superficial hemorrhages throughout the fundus. This is showing bilateral disc edema with macular star. The BP of 210 and by 100 millimeters of mercury. This is grade for hypertensive retinopathy. All right. So always remember, the case of bilateral disc edema, have to check BP. Absolutely have to check BP. All right. And then coming to case 10, a 30-year-old female with right eye decrease in vision since 1 week and left eye since 3 days. The visual acuity in the right eye was 3/60 and left eye was 6/24. Pupils were sluggish with a grade 2 RAPD in the right eye. There was bilateral disc edema. So any idea what this could be? The optic nerve function test show proper optic nerve pathology. This was a bilateral optic neuritis. All right. So there was bilateral. Here again, you can see the T2 hyperintensity in both the optic discs when compared to the muscles. Yes. And this was a MOG-associated optic neuritis. So finally, case 11. You will come across one of these cases. You will misdiagnose this case as an IIH. All right. So look out for it. A 60-year-old female with headache since 2 months, defective vision of 1 week duration, history of hearing difficulty, alopecia, MRI done, was seen by an ophthalmologist, was on treatment with Diamox via heads, but there was no relief of headache. Her visual acuity was 624 in the right eye and 612 in the left eye. Pupils were normal. Anterior segment showed granular matrix KPs. There were, and this was the fundus findings. Media was hazy. There was bilateral disc edema with other findings suggestive of posterior uveitis. What is the diagnosis? VKH. So always make sure you know this in your mind. Bilateral disc edema, severe pain, headache can be VKH. So in take-home message, disc edema can be bilateral or unilateral. Then you see whether it is associated with normal vision or decreased vision, and further similarly with unilateral disc edema. And then whether the decreased vision was gradual or sudden. Thank you.